All right, well, good afternoon, everyone, and welcome on behalf of Rhode Island Public Health Association to our second event this week. We are really excited to release a data brief on the topic of COVID-19 vaccination, specifically debunking vaccine myths, which is so hot, very hot topic for right now. My name is Patty Risica, and I am the advocacy chairperson for Rhode Island Public Health Association. But I have presenters also, or I should say hosts also, Tess Diatley and Anthony Sirachi, who are the data brief authors and editors for this brief, as well as the other brief that we released on just Tuesday. So this is very exciting. I'm happy to turn over our introduction and initial presentation to Tess Diatley.
Great, thanks. Welcome everyone, and thank you for tuning in today. Before we get started, I wanted to give each of our panelists, Dr. Vivier, John Fulton, and Paula Foster, an opportunity to briefly introduce themselves. We have a series of questions that Patty, Anthony, and I have drafted up to guide our discussion today. But before we get started, Patrick, would you like to introduce yourself, and then Paula, we can move on to you?
Sure. My name is Patrick Vivier. I am a pediatrician by training and also a professor in the School of Public Health at Brown, as well as the medical school. And I'm the director of the Hassenfeld Child Health Innovation Institute.
Great, thank you. And Paula, would you like to go next?
Sure. Hi, my name is Paula Foster, and I'm an RN. I am the manager at the VNA for the infection control program, occupational health. I also do emergency preparedness and safety, and the vaccine program. So we wear a lot of hats, like all of us do, correct? And this past year has been very busy, as it has for anybody who's worked in infection control. I'm glad it's winding down, but I appreciate the invite, and I hope I can be of help to all of you today.
Thank you. And Patty, I'm not able to see, was John able to join us yet?
Yes.
Okay.
Yes, he's here.
Hello. Yeah,
Hi.
I'm John Fulton. I'm a clinical associate, a professor of behavioral social sciences at the School of Public Health, which is a fancy way of saying I'm an epidemiologist. I'm a retired associate director of health for the Rhode Island Department of Health. And I have been working for a year or so back with the health department as part of the state's epidemic modeling team.
Great, thank you. And I think we're just really lucky to have so many experts on this panel today. So hopefully it will be a really fruitful discussion. So just to give people a brief overview of kind of how our 1 hour is going to be spent, I'm just going to provide a brief overview of what the data brief actually has in it. We've just done panelist introductions. After that, we'll move over to the panelist discussion. And I just want to invite audience members to drop any questions that they may have in the chat. Patty, Anthony, and I are going to do our best to kind of monitor the chat and moderate based on where the audience wants the discussion to go. So that's our agenda for today. And in terms of what the data brief that Anthony and I worked on together entails, it's certainly been like quite a year to learn about infectious diseases, and more recently how vaccines and vaccine distribution works. And the Rhode Island Public Health Association is just really excited to release this data brief on vaccines with the emphasis on myths and misperceptions. So the data brief is broken up into 6 sections, as you can see here. And we really want to invite folks on the call to provide feedback. I think right now it's in the phase of like soliciting public feedback for, anything that people would like to see maybe changed or improved or clarified that among members of the Rhode Island Public Health Association. And then after that, it will be posted online. So that's all I have in terms of kind of the overview. I'll stop sharing my screen now, and I think we can get started with the questions. So to start off, I thought that we could ask our panel to kind of speak about their impressions on how vaccinations are going in Rhode Island or in Providence more specifically. Would anyone like to start?
I can start. I as the maybe the least involved, and then Dr. Fulton or others can jump in who've been more involved. I think there's always in something like this the good news and then the challenges. I think that the good news is if you look at least at the latest data I've seen, Rhode Island, I believe, is ranked 6th among states and should feel good about that. But we in Rhode Island have a very long history of not being satisfied with number 6, particularly when it comes to immunizations. And there's still more for us to do. So I think it's one of those messages of feeling good about what's been done. And when you're in that sort of ranking among states, feeling good about our state and feeling good about our health department and the leadership and what they've been able to do in government, and others who've really, really jumped in. While still acknowledging there's a lot more we can do and need to do if this is going to be under control, would be my sort of immediate overall thoughts of things.
I would say that we're doing quite well. I would agree with what Patrick said. There are challenges. It is very clear from to me, from the literature that one's propensity to get vaccinated or not, if given the opportunity, if given really perfect access to vaccination, the decision to be vaccinated or not is very dependent on level of education, which I would translate as health literacy. It is difficult to pump up health literacy on a dime, as it were, so on. The modeling team, on the basis of national survey data and Rhode Island survey data, modeled a ceiling, a soft ceiling for vaccination of about 70%. Again, we were beginning with 16 persons 16 and above. Of course, we're now vaccinating 12 to 15-year-olds, so on and so forth. But we're very, very happy to see that we've not only exceeded that 70% mark, but are slowly inching our way up. And we're doing that sort of one age group after another on the way down, because we started with the oldest age groups. And as a sociologist, I'm fully expecting the neighbors, the effect of the neighbors to take hold. Look on your right, look on your left. Oops, everybody's vaccinated except me. Maybe, so on. So we'll see. But I think we're doing very well. I think we're doing very well, and we'll continue to do very well.
I agree. I think the state has done a phenomenal job on, I believe I heard yesterday on the Department of Health call that we had 72% of 18 and older partially vaccinated, with 62% of the total population fully vaccinated, and things are trending down. Here at the VNA, we have 85% of our staff vaccinated, which, we're leading in all the numbers for the system, and we're very proud of that. We still have 15% though. And our staff have good access, and they've had the education, they've gotten the information, but we still have 15% of our staff who are believing in some of these myths about vaccine. So we still have to work on them.
Yeah, thank you all for, I guess, highlighting the silver lining of what we're coming out of right now. And John, I would love for you to expand upon what you mentioned with health literacy as an ongoing challenge. What is the state doing right now to maybe address that the best that they can, given the time constraints and, you know, the need that is clearly relevant right now?
I wouldn't say they are tackling health literacy head on, although they are doing their best, as you are, to debunk myths and so on. What they are doing is approaching smaller groups, looking for what we call cold spots. It's actually Dr. Vivier that got us into mapping stuff about whatever 40 years ago, something like that. But we look for cold spots at places that have not, where vaccination is not as high as it may be. We are going there and using a variety of techniques, just a variety of techniques to make sure that people have full access, and that we meet concerns. We listen to them and meet their concerns.
Thanks. And Patrick, I don't know if you have anything you want to add about the cold spots in particular. I think that kind of segues nicely into a follow-up question that we had on kind of like the specific methods the state is exploring to have outreach to communities of color, if those are among some of the people that maybe are hard to reach, or if there are other groups that, you know, there's specific outreach work being done. I think it would be great to kind of share that with the folks on the call today.
Yeah, I didn't have much more to add in terms of the health literacy issue. You know, I think whenever we see things like cold spots, we need to think of multifactorial things. We need to think about what are families' beliefs, where have we not communicated clearly. We also have to think about what are barriers. Sometimes things are not necessarily resistance or hesitancy. It's not as easy to do as one might think it's easy to do in every community. So I think the state has been trying to do all of that, and I think John and Paula can probably speak to that more specifically. But I think we always want to, when we see a phenomenon, not reduce it to one thing, and really think of what are all of the issues that might be affecting that community. So John and Paula, I don't know if you want to jump in the activities that both of you are directly involved in terms of reaching that 15%, as you mentioned, Paula, or some of these cold spots, John.
Paula, do you want to comment?
I was going to say, for us, for our patients, we have our staff actively asking patients if they do want a vaccine when they visit. And the Department of Health sent out a few months ago a list of all the to all the municipalities what services were available to do in-home vaccinations, and I have that list posted on my bulletin board actually. So when a patient calls and they want a vaccine but they can't get out to get a vaccine, they can tell me where they live. So if they tell me they live in Foster, I can give them the number from MedTech Ambulance, and that ambulance company will go to the home and give them and anybody in the home a vaccine. And so we have all the municipalities listed, and this has been invaluable to our home care patients that cannot get out. VNA also was able to secure some vaccine from the hospital, and we have what we call here a flu crew who does all of our flu vaccines in the home. And they were able to get out to our bed-bound patients initially in the beginning when vaccines first started to administer vaccines. There was some trials and tribulations with doing that. VNA didn't have the freezer capabilities, and getting the vaccine from one place to another. There's always some lots of things you have to think about in detail. But those are some of the things that we've done here to try to increase the number of patients that are home when they can't get out of the home. That's a barrier. The other thing that the Department of Health is doing is they're starting, I believe it's this weekend, to do drive-throughs. And they're going to be doing those drive-throughs So at Fidelity in Smithfield, they're starting at, I want to say it is this weekend, 6-6. So yeah, that's this coming weekend. So anybody who can get out and get into a car can go to the drive-through and get a vaccine. They won't take any walking patients, but they will take anybody in the car. So you can drive through and get a vaccine. So that's another barrier for a lot of our patients. They can go and get their vaccine there.
One of the things that I think is actually most important that we are just beginning to do is actually enlisting our primary care physicians and PAs and nurse practitioners and so forth, our primary care folks, getting the vaccine out to practices. So we're just really beginning to do that. Why? Because there are, as my fellow panelists have pointed out, these issues are multifactorial, and I think they can be best addressed for anyone who has a regular healthcare provider by the healthcare provider, him or herself. Okay, who knows the patient better than, and so on and so forth, and can address individual issues in a very individual and personal way. And by the way, obviously the barrier to that previously has been two things, right? First of all, for the Pfizer vaccine, the need for a sort of deep refrigeration pretty much until use, and also not wanting to get vaccine in as many arms as possible without wasting any, because it languished in a refrigerator at 40 degrees or 35 degrees for too long, and so forth. But at this point, where we have a much greater cushion of the 2-dose vaccine and so on and so forth, we really can afford to push it down into primary care practices. And I think that that's very important, including community health centers, of course, to get to people.
Yeah, thanks. I think it's like a great point, just how valuable it is to have like a trusted healthcare practitioner kind of ameliorate concerns that people have. And we all know that they're very, very real. We wouldn't be producing a data brief on MIS if people, weren't skeptical. And I think kind of along those lines, and we have a couple things in the chat too. So I was thinking we could maybe redirect conversation towards this. But what might members of the audience say to friends and family who are skeptical of the COVID-19 vaccine? And, given that vaccinating children is certainly a topic of discussion in the news, could we also talk a little bit about why children should or should not get the COVID-19 vaccine?
I look to the pediatrician in the group.
I can start and then we can move on. I think, first of all, I want to echo what you were all saying before of engaging the primary care providers. The person, when you have individual questions about you or your children, the person best able to assess that is your primary care provider. And so I would encourage families when they have questions to really engage and hear what those primary care providers are saying. And most of them have been immunized, right? I think that's the first statement. So, I think the other is to really look at where our trusted source is. We none of us on the call are doing the direct viral experimentation in the mRNA or any of these things. We're all consuming information from the best possible sources we have and relying on organizations like the American Academy of Pediatrics and the CDC are the ones that we rely on to give us the best information possible. And all of that information is universal of this need for immunization. And we're seeing that impact of disease rates coming down as immunizations are going up, as we would expect it to be. We have the history of this happening with other vaccines where we've had this incredible success. And so I think we have to all, as the threat wanes, which we hope it is waning, to really remember the incredible toll that has been taken in the last year in terms of life lost and morbidity, and to do the things we can do. And the strongest thing that we have to do is immunization. There's always the challenge in starting immunizations of where you start the studies and which age groups and which vulnerable. And I think, unfortunately, kids are not always at the top of that, but, in some ways because of just concerns. But all the evidence we have is that this is safe in children. And as we're trying to get to these next steps in these immunization numbers, if we're going to protect one another as a society, we need to get immunized, including those groups that are younger, so that as the evidence comes in strong enough, and they lower that age threshold, I think it's important that we do it. I also think, speaking as a pediatrician and just as a person, the toll that has been taken of the change in our lifestyles for our kids in terms of school and what they can do and their social interaction, anything we have to do to help our children get back to a more normalized social interaction, we need to do. And I think top on that list is immunizing.
I would like to just add that, we don't have children on service, but I hear from the Department of Health that, the flattening of the curve in that age group, the 12 to 17-year-olds, there is no flattening. In that the disease tends to be higher in that group, more so now than the older group, because we're getting vaccinated. So it makes sense that we do put some efforts into getting those adolescents vaccinated.
Thank you. John, did you want to add anything, or should I pose a follow-up question?
Just to say that as an old Department of Health hand, I can tell you that for the spreading of infectious diseases very efficiently, 15 to 24-year-olds are very close to the top of the list. They can get around. Socializing is very important to this group, and through just normal, healthy, non-nefarious behavior, it's very easy. It's very, very easy for these folks to spread transmissible disease like a COVID-19. And so again, so as not to overly restrict this group, or to simply to allow them, to afford them the freedom that is good and healthy for them to have. A vaccination is a great idea, and as soon as we have it for younger children, say through age 11, hopefully in the fall, for the opening of schools, allowing kids to be kids in schools and see one another, and be sitting together, and being able to play sports without masks, and so on and so forth. This is just critically important for the mental health of kids.
And I just saw in the chat, there was a very specific question of, is it safe for kids? And so I wanted to make a direct statement about that. All the evidence that we have, all the experts are saying the answer to that is yes. And so, I think that's why we need to focus on that information, as well as what John was just saying in terms of what is the cost of having our children remain at risk.
Right. And I guess follow-up question to kind of the safety for children, which you just addressed. Are the side effects of the COVID-19 vaccine any different for children or adolescents compared to adults?
John, did you want to take that one as from working on this? For adolescents, there's no noticeable distance. This is not a higher risk of side effects, and side effects for all of these vaccines, with the exception of the normal, just normal vaccine side effects of discomfort and that sort of thing the day after. there are very, 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 very few serious side effects of these vaccines. And let me say one more thing. I have never seen scrutiny of vaccines tighter than for these vaccines at the present time, okay? So to the extent that we are counting and slicing and dicing appropriately, the side effects, more serious side effects, so on and so forth. I think we know more about these vaccines, frankly, the rollout of these vaccines than any vaccines I've seen previously. I think we're catching just about every serious side effect, and therefore we can trust the numbers on the side effects and the qualitative description, you know, how serious are side effects and so on and so forth. And they are very, very, very minimal.
Yeah, I would echo, you know, nothing that we do is 100% safe. So it's appropriate for people to have concerns. I think this loops back to what we said earlier. If you have concerns, please talk to your pediatrician, talk to your family physician, your internist, and work through them. It's not in any way to dismiss concerns. There are side effects to this vaccine, as there are things that can happen with every vaccine. We've not seen in kids. Kids have, in general, more robust immune systems, so they may have a little bit more robust of some of these expected side effects. But we haven't seen anything, and it is being looked at very closely. As we, you know, always have to continue to monitor, and anything that we do, you want to continue to monitor the things that we might know tomorrow that we don't know today. But we have to act today. So today we have to use the information we have, and as Dr. Fulton said, there's quite a bit of information and tremendous expertise looking at this information and all pointing towards this need to get kids back to school and to get this pandemic under control.
Agreed. And I think to John's point about just how robust the, like, you know, monitoring the evidence, the implementation process has been. I was hoping that you all could kind of speak to some of the lessons learned over, you know, the last, you know, I guess like 4 to 6 months in preparing to roll out the vaccine, and what we might do differently should a new illness reach our population. That is, I mean, hopefully we don't deal with a global pandemic of this magnitude in any of our lifetimes, but certainly, you know, I never thought that it would happen, and here we are. So I think that it would be great if you all could speak about that a little bit.
This should definitely be John and Paula who handle this. The one thing that I will say of the lesson for me is less about what was specifically done for this and more the lesson for us to learn of the importance of public health. And I applaud all of you in the Rhode Island Public Health Association. The biggest lesson to learn is to have our public health systems prepared and ready and sufficiently funded and sufficiently focused on before these things happen. And so I want to make sure that doesn't get lost. Sorry to jump in with that specific thing of probably our biggest lesson is we don't know what the next public health threat is going to be, but we know there'll be one. And this one taught us that we were not as ready as we should have been and right at the beginning. And that's because we don't have systems in place before it happens. So I would just make that one plea as John and Paul will be much better positioned to talk about the sort of specifics of how things have unfolded. But if we can get to a safer time, we need to use that safer time to worry about what's coming next and really focusing on our public health system.
I would say this, there are, I would say from my own perspective that there were 3 problems that I would like to see us address with regard to vaccine rollout. And I'm taking nothing away from my colleagues who for whom I have the greatest respect, who got the vaccine out. There are three things. Again, one, the greater clarity of message. Okay, greater clarity of messaging, setting expectations straight up front about when vaccine would be available, helping people set expectations, okay, so that we did not, so as not to violate expectations about when vaccine might be ready for them. Now, in all fairness to everyone who worked on this, we were doing this on the fly, and some promises of the federal government were kept and some not. Not for any nefarious reason, but simply because, as that famous bumper sticker that says, things happen, and things do happen in the distribution of any item, the sort of a national distribution system, so on and so forth, and there are breakdowns. But managing expectations just a little bit more tightly in the beginning, that's number one. Two, clearly, with regard to signing up to get a shot, shall we say, just to put it like that. I think we've learned a lot of lessons. I think our IT systems are better at the present time, and better, easier, more transparent to use, so on and so forth. It was difficult. It was difficult up front to schedule vaccine, a vaccination, and I'd like to compliment our colleagues at CVS and Walgreens, because I think they did a marvelous job with their registration systems. They were simpler, more transparent, and so on and so forth. It took us a while to catch up, but we did that. Again, this is an infrastructure issue. And finally, look, for a few weeks, there was a muddling through process, as you may have noticed. Okay, what do I mean by that? Well, for a few weeks, we were not getting vaccine out as quick into arms as quickly as possible, and I don't have a solution to that problem because I haven't analyzed that problem. Okay, but I have, we know. I think my colleagues know what that hesitancy was about. And I think we'll be in much better shape the next time to avoid that. Having said that, again, things happen, unexpected things happen, and there is a little muddling through always. Just-in-time training is not quite just in time. Things take a little time and so forth. So there's always a little bit of period of kind of muddling through. But I'd like to tighten that up, and I think we can learn a lot from our experience in this year.
I agree with everything they just said. One thing I would like to add is that I think here, with this process this year, I think the thing we can expect is change. You know, every time we turn the corner, there was a change of something, some process, you know, a change in schedule, a change of, you know, having to cancel patients we've already scheduled to get a vaccine because we couldn't get vaccine. You know, and absolutely the signing up process. You know, not only do we take care of patients, we take care of their families and their neighbors and their friends, you know, in trying to assist them in getting a vaccine, and the difficulty with them trying to get online to sign up to get a vaccine. It was very frustrating. So those are the things that I find were hard, and hope, you know, if we ever had to do this again, we'd be a little bit better prepared. But you know, you have to expect change, and you've got to be a little flexible.
Great, thank you. Anthony or Patty, do you want to, you know, follow up on anything we've talked about or ask a question?
Yeah, so thank you for that. Yeah, because I was thinking about something I think the panel said earlier about kind of dealing with some of the beliefs around COVID-19. So like in my own example, so anecdotally, or at least in my own case, like I can think of family members whom I know who are roughly my age who are not getting the vaccine for concerns about these side effects. For example, one of my cousins is concerned it would impact her fertility later on. Even though I've explained to her there's no evidence of that, it seems to be a very firmly held belief. I'm just curious, like what, you know, because I'm just curious, like the panel's perspective on like things we can do as individuals, like with people in our lives who are vaccine resistant, let's say, like what might be an approach we can take to explain to them what the science means? Because I think health literacy is the same issue like you were talking about before. I was just curious, like what are some things we can do, some tangible steps we can take to kind of alleviate or address that barrier, let's say?
I've done a lot of thinking about that, and I will tell you something that I would not do. I would not pepper anyone with arguments in favor of vaccine or argue with their position, as ill-informed as it may be, or as not informed as it may be, but listen to them. Everything that I have heard and seen, and we've been searching, trust me, we have been searching the literature on this. Is it the best approach? The best approach to persons who have access, and in fact are hesitant, and in fact have a rationale for their hesitancy, is to listen to them, make sure that we listen to their concerns, understand their concerns, and then simply suggest, well, you know, maybe you need to find out a little bit more about this. And why don't you speak to your physician? It's always safe to say that. Speak to your physician. In this case, speak to your gynecologist. Speak to, you know, and so on. But to listen, to affirm the person's concerns. Some of which, you know, who knows. Someday may turn out to be real, right? We base a lot of our knowledge on aggregate information, but there are cases way beyond standard deviation and so on and so forth. So again, listen, refer, and say, well, good. You know, maybe you'll feel a little bit better about this, or maybe we'll know more shortly, and you'll feel more confident, or not. In pursuing one course or another.
I'd like to add, Anthony, I told this group that we have 15% of our staff who have not been vaccinated, and less than 5% of that group are pregnant employees, some employees who are still nursing, and employees who are of child rearing ages who are concerned that there's not enough data available, and they're concerned about DNA changes, they're concerned about hurting their child. I do refer them to their doctor, to their physicians, to their pediatricians, to their gynecologists, to speak to them, and you know, I'm not going to begin to tell them that it's a good idea. I still think you can. The evidence says it's okay that you know, and that it's not going to hurt you or hurt your baby. I wouldn't do that. I refer them out, but it's a good percentage of the staff that we have not gotten vaccinated here.
By the way, let me point out something. There are very few public health programs that we field where we get better than 85% participation. Okay, look at the best we've ever done with mammography screening, getting women getting mammograms on time is a little little bit north of 85% in the state of Rhode Island. It's under that at the present time. And we have been working since 1986 on that issue. It's obviously much more enculturated, ingrained, and so on and so forth. We rarely do better than about 85%.
So this is so helpful. We also have quite a few questions in the chat, so I'm going to bring some out and really tying into some of what Paula said are some of the concerns of your staff. Can you talk about, in layman's terms, the connection between the vaccine and our DNA, and why there is or is, what the concerns are voiced that in some way the vaccine changes our DNA? Can we speak to that issue?
Sure, it doesn't.
Right.
It doesn't. I understand what the issue is, and I understand why people are concerned. Why? Because an mRNA vaccine, okay, uses RNA, right? Getting a foreign RNA into our cells to produce what? Spike protein, to which our immune system responds, and so on and so forth. Okay. By the way, the infection by COVID-19, which is far more serious, does something worse than that. It's similar, it's analogous to that, but worse. So let me suggest to people that if they are concerned about having foreign RNA being produced by their own cells, there's a lot less that's actually produced in a vaccination. It's much more localized and so on and so forth than a generalized COVID-19 infection. But I understand why they have the concern, right? Because we are using that RNA to get our cells, right, into our cells, in this case, into the muscle cells of the arm, and so forth, to produce spike protein, et cetera, et cetera. So it's like, whoa, you are modifying my cells. Well, yes, but any viral infection does that. So I think that kind of explanation would be, by someone like Dr. Vivier, who's better at it than I am, would be helpful.
I know he's not better at it than you are. I think you said it exactly right, Dr. Fulton. I think, I think really two critically important things that Dr. Fulton was just saying that is the way we have to do, is we have to take seriously people's concerns. Sure, if you had a choice today, do I want mRNA thrown into my body? No, I don't, but that's not my choice. My choice is, do I want it done through a vaccine in this controlled way, or do I want that risk of it done through an infection? And so the question isn't, is there exposure to this out there? It's how it's going to happen. So I think we always have to ask ourselves, compared to what? And so that concern, that theoretical concern, right? We don't have it as a scientific practical concern yet, because there's not evidence, but why people might have that hesitancy. Again, going back to what we've all said, those are legitimate concerns and we should work through them. But we should make sure that discussion is not, do I have the vaccine or live in a world that's completely safe where I don't have to make any decisions? We have the question of, do we have a vaccine with lots of safety information that can prevent this exposure, where we've seen what this virus has done, not only in who it's killed, in the morbidity, and some of the lasting, and though we don't know, just as people are asking questions, might there be some long-term around the vaccine? We always have to keep looking for that. Might there be some long-term on the illness, even if it were minor? We need to worry about that. So I think that people have to say, compared to what? We make decisions to protect ourselves because there is a threat. And so as you're thinking of the pluses and minuses of that protection, you need to give at least as much attention to the pluses and minuses of that threat.
Sure.
So I thought that was very important, what you said.
I think that makes a lot of sense. And I think it's unfortunate that there's also a message out that somehow our DNA is affected, and just it's a difficult thing to explain, but I think a lot of folks don't understand that DNA is not changed by RNA. It's the other direction. And that our, so by just telling folks it's not, like John initially said, it's just not the biology. It just doesn't go that direction. But I can't even think of a better way to just say that it's just not how the biology works. But there's another question. Yeah, sorry, go ahead.
No, please.
There's another question on, can you provide any thoughts or information on thromboembolic phenomena in infected and in vaccinated individuals? What do we know about that?
I'm not a particular expert on that and have not studied it, so I would defer to my other two colleagues.
Neither am I. We certainly have had rare cases of those events, widely publicized and widely scrutinized. By the way, this is not. This is for only certain types of vaccine, and interestingly enough, I believe the person is referring to the Janssen product, the Johnson & Johnson vaccine, correct? Yeah. That uses a modified adenovirus for basically doing something similar to the mRNA, but a little different, but a modified adenovirus. As it turns out, vaccines made in that way, and by the way, that is a more old-fashioned way of making a vaccine, huh? So that technique has been around longer, considerably longer than the mRNA technique. Okay, as it turns out, that problem, that side effect, has been noted in other vaccines made in the same way, made in the same way as Johnson & Johnson. So not just COVID-19 vaccines, but others. Nevertheless, so we have information on that. So it's not the COVID-19 aspect so much, but it's the mechanism. It's the way the vaccine is made and works. And we've been using that type of vaccine for quite a while. We have considerable information on that. And in fact, this is a rare but noted side effect. And there's no, I mean, that's simply a fact.
Okay, thank you. So another of our listeners is a social worker, and she really brought up some very interesting points about some of what I think of as traditional barriers to access. And I'd like your thoughts on access to issues of very limited access to transportation, English language, technology, comfort, and limited education in general, and afraid of the vaccine due to maybe lower education. What can we do on those fairly traditional barriers, and what's already being done to really help folks get the vaccine and overcome some of those issues that some of which are really, the core of health literacy?
The techniques that I think we've done a very good job in Central Falls. Not perfect, but a very good job. We've had lots of people working in that particular community, not just that community, but I'm familiar with the health department folks who have been in charge of that. There's been a lot of individual contacting in the community, a lot of enlistment of trusted leadership in that community. And again, I strongly, I think there are only two, there are two solutions to the problems here. And I'm not, and my main solution is trust. Okay, it's trust. Vaccine has to be discussed in a relationship of trust, okay, with I believe, a healthcare provider, okay, someone whom the patient or the client trusts for this kind of information, someone with whom the patient has had what we call a continuity relationship for some period of time, so on and so forth. Someone, and there are other ways. I mean, one can talk about other ways of, getting around transportation problems and so on and so forth. But I'm not so sure, frankly. If someone came to my door and knocked and said, with a needle in their hand, and said, "Hi, here's your vaccine. Roll up your sleeve." Again, is there not a trust issue? Would we not? What would we feel? But so it's not. So yes, transportation is certainly a significant issue, and I think Paula has already spoken to some of that with homebound and so on and so forth, individuals and so on and so forth. But again, critical to this, critical is a trusting relationship. We began with sort of trusted leaders, Dr. Rodriguez, in communities with many Spanish-speaking people, so on and so forth. We started with that kind of leadership, but now sort of getting down to the provider level, I just think is critical.
Thank you. And I want to be conscientious of everyone's time since we're getting close to the hour here. Maybe we have time for this last question here that someone asked to the panel. If you all think that mandatory COVID vaccination for healthcare workers will be implemented by the Department of Health as a directive, such as influenza has been, and then when is full approval versus emergency use authority expected to occur?
Can't I pass the baton on that one?
I'll try to answer it. I don't think it will be mandated yet. Like flu, we had to take baby steps. I know as a system here, what we did was we did it in levels. We started with physicians within the system first with flu. That would be, the first ones to, mandate getting a flu shot. And then we started with management level, and then we worked to, students, and then volunteers, and then maybe new hires. And then eventually it was, mandated for all staff, except those with a medical exemption. We may see that happen in the future. I don't think it's happening yet. I think we're seeing some baby steps. We are within Care New England, as far as, volunteers and students, and we're working our way. We have timelines where we may see, other areas where we, like new hires, but I don't think the state, I think they're thinking about it, but I don't think it's going to be mandated yet.
Yeah, thanks for that input, Paula. I think that is probably really helpful for this participant to hear your thoughts on it.
By the way, I would agree with that. Teresa, what was your second question? There was a second question about emergency.
Yeah, when is full approval versus the emergency use authority expected to occur?
From what I've heard, soon on the mRNA vaccines. It's soon. Again, that in itself is an application process. It's not just something that happens. Okay, it's a very formal process where additional data are, again, the vaccine has now been used on a population basis, so on and so forth, and we have recorded what we, as we've discussed here, We've recorded side effects, untoward side effects, so on and so forth. So again, each manufacturer has to apply again on the basis of this kind of information, the track record, as it were, and again, it's a well-structured, formal process.
I think that's helpful to hear, and certainly should give people even more confidence in just kind of, you know, how much thought is being put into the, you know, the rules and regulations that surround implementation. So yeah, thanks for sharing that. And I guess since we only have a few more minutes, just wanted to maybe give you all the opportunity to share with folks on the call today where they can go to get more information about the COVID-19 vaccine, or where they could book an appointment if they haven't already.
I don't know if you can answer that, John. Certainly the Department of Health's website is there and has a ton of information, and I think would be the go-to spot. And as we've said more and more, to your primary care physician. And I think we said a little bit at the beginning, just to take this opportunity to really acknowledge, you know, Dr. Nicole Alexander-Scott and her leadership, and the Department of Health, and all the folks, the Rhode Island Public Health Association, the incredible work that's been done during this time period that we have a lot to be thankful for. And all of those essential workers, the folks who have continued to, the pediatricians and physicians and nurses and everyone who's continued to see patients, or those who make sure our grocery stores are still open, that in this time of, you know, tragedy, we have a lot of people to thank for how we've been able to get through. So just didn't want this to end without having that opportunity to say that.
I don't think I could have said it better myself. Thank you for saying that. And I think that that's maybe a good note to end on. Patty, did you want to add anything before we wrap up?
I just want to say thank you so much to all of our panelists. Thank you to Tess and Anthony also for creating this brief. I actually added the link to the COVID website at the Department of Health into the chat for anyone who is interested. And also, if you're not already a member, I hope you are, please join us at ripha.org. And also, we will have other data briefs released, and other data brief release events to hopefully keep all of us up to date on some of these very important public health issues. So thanks everyone also for coming today and for participating.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Take care.
Thank you.